moderating today's session. Before we start, I would just like to note that all attendees and participants are muted by default. We will have presentations from 4 panelists today, each of about 10 minutes each. And then these will be followed by a 20-minute question and answer session. So if you have any question that you would like to ask or to direct to any of the panelists, you're invited to submit it through the Q&A feature at the bottom of your screens. Please note, please don't use the Q&A feature and not the chat box. So with this feature, then the attendees can vote up the questions they agree with. And at the end of the presentations, I will select some to direct to our esteemed panelists. So just by quick way of context, this is a continuation of the webinar series that we started last year on lessons from the COVID-19 pandemic. Since then, we've had almost a dozen webinars promoting the importance of strong global, regional, national coordination for the COVID-19 disaster risk reduction and advocating the need for a multi-sectoral whole of society approach for preparedness, readiness, response and recovery to the pandemic. But as we know, the impacts of the pandemic are far from over, and we need to continue and intensify our efforts in sharing of our experiences and actions and lessons learned. So this year, we will kick off the COVID-19 hospital webinar series with a focus on managing pandemic risks in health facilities, recognizing the critical role that health facilities, the frontline health facilities play, including hospitals, healthcare facilities such as long-term care facilities, the role that they play in controlling the pandemic. So in this first of the series of this year then, we will hear from the practical experiences of countries in managing risks in hospitals. We will learn about guidance available to strengthen continuous assessment and monitoring of health services, preparedness, capacities, and their readiness, and highlight and discuss some of the issues and implications for vaccine preparedness and readiness of health facilities as COVID-19 vaccines become available. So without further ado, we are honored to invite Dr. Stella Chungong for our opening remarks. Dr. Chungong is Director of the Health Security Preparedness Department within the Health Emergency Program of the World Health Organization. Dr. Stella Chungong, you have the floor.
Thank you, moderator. Good morning, good afternoon, good evening to all participants who have joined us from around the world and to our esteemed speakers for this very important session. I am pleased to welcome you all to the first webinar of the COVID-19 Safe Hospital webinar series in 2021. I thank the United Nations Office for Disaster Risk Reduction, the International Hospital Federation, and WHO colleagues for organizing this timely event to support COVID-19 safe hospital capacities. This webinar series aims to facilitate learning from country experiences and identification of best practices at the hospital level that can address health security challenges and which can enhance essential health service delivery. This webinar series also aims to support greater understanding of hospital level needs to better prepare against emergencies and disasters in the light of the lessons we have learned from COVID-19. The series carries with it a sense of urgency given the continued impact of COVID-19. As of today, the pandemic has resulted in just over 100 million confirmed cases and over 2 million confirmed deaths. The pandemic has underscored the threat of hospital-level infectious disease transmission and the importance of preparing against hospital-acquired infections. It has also highlighted the critical need for continued essential services and the value of investing in hospital preparedness to mitigate the impact of emergencies and disasters. WHO has developed a suite of health service capacity assessments in the context of the COVID-19 pandemic, with guidelines and tools that support the rapid assessment of health facility capacities in the context of COVID-19. This includes the WHO Rapid Hospital Readiness Checklist for COVID-19, which assesses hospital governance, structures, plans, and protocols to support countries in rapidly determining their current capacities and their existing gaps in hospital services that are critical to respond to COVID-19. The checklist also supports countries to identify major areas of hospital preparedness that require greater investments and actions to strengthen sustainability. In view of this and the urgency for better hospital preparedness in countries, the first session of this webinar is focusing on managing emergency and disaster risks in hospitals during pandemics and hospital vaccine readiness. We have invited a distinguished panel of experts to share their experiences and insights into hospital health emergency preparedness and disaster risk management, and to provide country and communities perspectives. As we go through this webinar series, let us prioritize identifying how countries, communities, and hospital settings can enhance emergency preparedness response and recovery. We need to capitalize on our collective experience and learn from each other across the world. And this webinar series provides us with an excellent opportunity to advance the whole of society actions towards stronger hospital preparedness. I welcome you all warmly to this hospital webinar series and look forward to the continuing participation of all in this. I thank you.
Thank you very much, Dr. Chongong. We will move on now, and let's welcome our esteemed panel speakers. Just before we do so, I just want to make a reminder to those who have recently joined that if you would like to direct some questions to the panelists, please do so using the Q&A feature on your screen. Also, interpretation is available in English and Spanish. Okay, so with that, please let me first invite Dr. Wangjun Lee. Dr. Lee is the CEO and chairman of Myungga Hospital, Myunggi Medical Foundation from the Republic of Korea. Dr. Lee, you have the floor for 10 minutes. And I believe Dr. Lee is presenting via video.
Hello, everyone. It's a pleasure meeting all of you. I'm Dr. Wangjun Lee, chairman of Myunggi Hospital and the general secretary of Korean Hospital Association COVID-19 Emergency Response Committee. I'm also serving as a board member of Korea National Clinical Management Network for COVID-19. As COVID-19 pandemic has prolonged, our key concern is how to operate the healthcare system in a seamless manner under this pandemic. Today, I would like to introduce some of Korea and Myunggi Hospital's experience in improving surge capacity amid COVID-19 crisis. First, I would like to briefly present Korea's current COVID-19 situation. The first confirmed case of COVID-19 in Korea was reported on January 20th last year. And as of yesterday, Korea is recording about 76,000 confirmed cases with a mortality rate of 1.8%. This chart shows the overall epidemiological curve in Korea. The third wave of the pandemic began in the middle of November last year, and it has recently passed the peak by taking stronger social distancing measures. As I shared in the previous webinars, Korea has been faithfully and successfully applying 4 T strategies, namely trace, test, triage, and treat for COVID-19 response. Among the 4 components, triage system is particularly related to hospital surge capacity. As the pyramid on the screen indicates, confirmed cases were classified by severity of symptoms into 3 groups for treatment. However, when the daily confirmed cases exceeded more than 1,000 for a couple of weeks in December last year, we also experienced the shortage of hospital beds. Further expansion of treatment facilities and manpower was indispensable for timely COVID-19 treatment. In an effort to tackle the problem, Korean government increased the treatment facilities by issuing an executive order to secure more intensive care unit beds and building more mobile container wards. As for the shortage of medical manpower, they recruited emergency medical support group. Now, I would like to bring your attention to Myeongji Hospital and its experience in coping with surge capacity amid COVID-19 crisis. Myeongji Hospital is a non-profit private institution with around 600 beds, located in the city of Goyang within Greater Seoul area. We run a level 2 trauma center and wide regional emergency center that covers 2 million population across the span of 3 major cities. Myeongji Hospital has experienced 3 times of virus outbreak. Since the swine flu experience in 2009, we have regularly conducted trainings and drills against the new infectious disease response. As a result, Myeongji Hospital successfully responded to MERS outbreak in 2015, and we are currently serving as a centric infectious disease control hospital during COVID-19 crisis. Since last January, 134 severe and critical patients were transferred to our hospital by the triage system. And the mortality rate until now is about 25%. This mortality rate means the severity of the patients. But I want to emphasize that there were no changes in providing essential clinical function for non-COVID-19 patients. The secret is the dual-track healthcare system. The dual-track healthcare system is a strategy to maintain the core functions of an acute care hospital while simultaneously treating both COVID-19 and non-COVID-19 patients by appropriately allocating medical resources. In other words, the purpose of the system is not about response to infectious disease surge, but rather about how to maintain the core function for non-COVID-19 patients consistently. This system was published in the Journal of Hospital Infection, and this article was recognized for its uniqueness. There are 5 key components in the dual-track healthcare system. The first component is compartmentalization in space and human resources. We specially separated the hospital into COVID-19 zone and non-COVID-19 zone, and assigned dedicated medical staff for each. By designating the entire building E as a COVID-19 zone, the rest of the hospital areas could remain safe. The second component is the use of buffer zone for inpatients. We have assigned the admission screening unit where suspected patients could temporarily stay until they are confirmed with the RT-PCR test results. The next one is to secure protected areas in the emergency department and outpatient department. According to the type of patients, we have run 3 types of screening centers. The fourth component is the in-house laboratory capacity. Our in-house laboratory operates 24/7 and has a maximum capacity of 400 tests per day. The test result is communicated to patients within 6 hours. The last one is real-time communication tools. The use of various real-time communication tools enables to separate areas to be controlled under one integrated system. So we are able to deal with ad hoc situations efficiently in timely manner. The dual-track healthcare system may not be an answer for all hospitals regarding surgery capacity. However, the key is how to mobilize the medical resources in a flexible and sustainable manner. Let me take a few more examples. We have transformed the pneumonia surveillance unit into negative pressure isolation units for critical COVID-19 patients. Furthermore, we equipped operating rooms and angiography rooms with negative positive dual pressure system for the upcoming demand. We prepared ourselves with new equipment like mobile CT and mobile X-ray machines in advance for effective treatment of COVID-19 patients. All these endeavors ultimately boil down to how hospitals can flexibly cope with the given situation and limited resources. In addition, hospitals should consider how to encourage hospital staff to provide sustainable medical services. Myeongji Hospital is not only provide various resilience programs for medical staff, but also scheduling alternative rotation teams for COVID-19 response to mitigate their fatigue. The same discussion can go on for vaccination plan. Under the central leadership of Korean CDC, several designated bio companies are currently discussing Korea's vaccine production and distribution plan. Each vaccine requires different conditions for storage, usage, and logistics. So vaccination sites will be established in dual track, one for ultra low temperature and the other for room temperature. In addition, IoT-based vaccination control center will manage the whole process, including inventory and transportation. Also, patient registration, data management, and follow-up will be managed through a mobile application software. Korea is seeking to kick off its vaccination program from next month, February. Well, this is all I have for today. Thank you for your attention.
Thank you so much, Dr. Lee, for this really excellent presentation, highlighting this this dual challenge, and then this dual track response for being able to respond to both COVID-19 while simultaneously assuring the continuity maintenance of other essential health services, which I think many countries are facing that challenge.
Ms. O'Neill, your audio is not working. Could you check again?
Dr. O'Neill, could you kindly unmute?
Is my audio working now? Can you hear me now?
Yes, very well.
Sorry, I must have a loose wire. So with that, I would like to move on and invite Dr. Chiari, who heads the Division of Monitoring and Evaluation in the Federal Ministry of Health from Kenya. Dr. Helen, you have the floor.
Good morning, good afternoon, good evening, and thank you for joining this webinar on hospital readiness to respond to COVID. I hope I am audible.
Yes, we hear you very well.
Okay, thank you so much. Yes, I'll go straight to the findings. I think the first speakers, alluded to the COVID-19 assessment tools for health facilities and communities in terms of assessing readiness to respond to COVID. And in Kenya, we have been able to deploy these tools to do a rapid assessment of readiness of health facilities and communities to respond to COVID. So I'll take us through some of the results, early results that we have in Kenya. Next slide, please. Yeah, so the COVID-19 situation in Kenya, as of yesterday, we had a total of 100,000 cases with 1,751 deaths so far. As you may know, in Kenya, we have 47 counties, decentralized governments. And in all these counties, we have had cases with the urban counties, Nairobi and Mombasa reporting the highest number of cases. Next, please. So I'll just quickly take us through an overview of the assessments, results on readiness of COVID, COVID treatment centers in terms of essential tools, the extent to which delivery of essential services have been impacted by the pandemic, and some of the key findings and recommendations, as well as lessons learned and next steps. So in terms of objectives and scope of the survey, we had two main objectives. The first one was to assess the current and surge capacity for COVID-19 treatment centers. So if I may mention, each of the 47 counties was tasked with, getting ready for COVID response by ensuring they have isolation beds as well as critical care beds, oxygen, and all these things. And the minimum that each county was to have was 300 beds in each of the facilities. So we have COVID treatment centers in the counties, and we assessed these treatment centers. So the first objective then was to look at the current and surge capacities for COVID-19 treatment centers. And the second one was to assess the extent to which health workforce at facility and community level are able to maintain essential services. And in Kenya, we deployed 3 modules, one to look at the case management capacities, looking at vaccines, vaccine readiness, therapeutics, diagnostics, PPEs, oxygen, with an aim to look at how are we able to respond and guide deployment of resources. When depending on the level of the pandemic per county and nationally. Then The second tool, that is continuity of essential services, we're assessing the health workforce capacities as well as the facility capacity to maintain essential services, just so that we don't neglect essential services which still need to be continued and therefore be able to mitigate any disruptions. And the third tool we used was the community tool that looked at community perceptions as well as the health needs, looking at the health needs and care-seeking behavior of the community at the community level, guided, to help us guide any strategies that may need to be put in place to address unmet needs at the community level, and also obviously look at the barriers to seeking care. Next. So in terms of methodology and sampling, we used we have what we call the Kenya Master Facility list, which is where we have all our facilities listed, and we're able to use this to basically draw a sample of the facilities that we needed to assess, and we did a purposive sample of 132 facilities. Out of this, and we had 131 respondents. Looking at the level of care in Kenya, level 1 is usually the community level, in which we assess 51 community units in all the 47 counties. At level 2s, we assessed 32 dispensaries. Level 3, we assessed 14 health centers. We had the primary hospitals, in which we assessed 48 hospitals. Level 5, this is a secondary treatment centers or hospitals. We had 22, and we had 5 national referral facilities. So next. So yeah, so the first objective, looking at the current and the surge capacity for COVID, we were looking specifically at availability of PPEs, COVID-19 safe environment measures, medicines, diagnostic capacities, vaccine readiness, as well as community acceptance and bed capacities. So some of the results we have, next slide, please. Yeah, so the results show that in terms of PPEs, that is the personal protective equipment for health frontline health workers, as you can see, almost all facilities had surgical masks, 91%, though we have few facilities, 5%, that reported not having surgical masks. In terms of respirators, we had just below half of facilities having respirators. So basically, we are looking at only 15% of facilities having all the required PPEs for health workers. And that includes protective gown, goggles, and all this. And therefore, there is a gap that we know that we need to address in terms of PPE. But comparing this with the baseline assessment we did in July, we noted that this item had quite a significant improvement in terms of performance. Next, please. So looking at COVID-19 safe environment as well as infection prevention, this is an area that we found that generally we are doing well. Most IPC measures are in place. However, only a third are actually screening staff, for COVID. Otherwise, most of the measures were well implemented, but few facilities didn't have isolation mechanism for patients. But generally, I think for IPC, this is one of the areas we are doing well. Next, please. So in terms of commodities, that is essential life-saving medicines, we assess a number of drugs, as you can see. And I think the general picture is that most of the commodities are available in the health facilities, although we note that only a quarter of facilities had all the tracer items together in one facility. However, the distribution of the available commodities was fairly okay. However, items like ampicillin, injectable, haloperidol, heparin are items that are of concern. Next. Then in terms of oxygen, as you know, oxygen is extremely important in terms of treating COVID-19 patients. So we know that all assessed treatment centers had access to at least one source of oxygen. In terms of supply, in Kenya, we are still having various modalities of supplying oxygen in health facilities. And we find that cylinders, which is an expensive way of sourcing oxygen, most facilities were actually using cylinders, and a significant number was using concentrators, while external supply, that is bulk supply of oxygen, was quite low, just below 40%, while the generator, which is the oxygen plant, the ideal situation was only available in 41% of our COVID-19 treatment centers. In terms of administering, oxygen, we find that we assessed a number of things. Most facilities had pulse oximeters. However, in terms of ventilators, we still have about half of facilities really not having invasive or non-invasive ventilators, and the situation is worse in rural facilities. Next, please. So in terms of diagnostic capacity, we were assessing whether treatment centers were carrying out PCR testing for COVID, and we find that there's a concern where only about 15% of our facilities are testing for COVID on site. Many facilities actually collect these specimens and send them to the testing labs, the reference labs. It works well. However, there's a challenge that comes with that in terms of late results. And we find that over half of facilities take more than 3 days to get their results, which is quite a concern. And the situation is much worse in dispensaries and clinics, the lower level facilities. Next, please. So we looked at vaccine readiness in terms of availability of fridges, and we found that most facilities had a fridge. For transportation, we were looking at cold boxes and carriers, vaccine carriers. And we found that most facilities had the carriers, but there's a concern where up to a quarter of facilities had cold boxes of vaccine carriers, but these were not functional. And most facilities actually indicated that this is an area they would like to be supported if we need to get ready for the COVID-19 vaccine deployment. Next. Yeah, so in terms of community acceptance of the COVID-19 vaccine, we talked to community health workers, as I mentioned earlier, and we found that about 2/3 of them were concerned about worried about the COVID-19 vaccine, and we find that when we asked whether they would get vaccinated, or the child, they would get their child vaccinated, or whether they thought people in the community would actually get vaccinated or get their children vaccinated, we find that their feeling was that only about less than 50% of the population would actually either get themselves vaccinated or get their children vaccinated. So this is an area where we need to put a bit of effort in terms of community health education in terms of the COVID-19 vaccine. Next.
Dr. Helen, can I ask you to finish up shortly?
Yes.
Thank you.
Okay. Okay. So just summarizing the COVID-19 case management, as you can see, this graph indicates that for supplies, that is syringes and other non-pharmaceutical items, we were doing well. However, our main area of concern is PPE items for all staff. Next. We compared the availability of guidelines for management of COVID-19 with what we found in July, and we found that generally availability of COVID-19 guidelines was quite fairly okay in facilities, but there was also some significant increase since the last assessment we had done in July, but generally the source of information was distributed along various sources. Next. So next, please. In terms of healthcare workers' infections, again, we found that there was a concern with the clinicians, with the medical doctor being the most affected, and this is consistent again with what we found in July. But the percent here has actually gone up. I think in July we had less than 1% of medical workers getting infected with COVID. So this is an area of concern. Next, please. In terms of essential services, we found that there was disruptions in some of the critical essential services, with about half of facilities having decreases in sick child visits, and about 40% having decreases in family planning clinics, antenatal and postnatal care. So the situation was really distributed again across the various services, but we found that services targeting children and women were really affected at the start of the pandemic. Next. And then in terms of responsiveness, what facilities did to to mitigate the decreased essential care seeking, we found that facilities had modified their operations. Some changed the operation hours. Some others targeted high risk patients, use of prescriptions, and all these measures were implemented fairly well, I can say. But then there's still a lot of room for for improvement if such a situation was to really happen again. But I want to mention that as of now, most essential services are back to the pre-COVID situation. Next, please. Yeah, so I think this is just a summary. Maybe this has come out in the presentation. So we can go to the next slide where we're looking at the lessons learned in terms of this phone survey. So sorry, I think I forgot to mention that this assessment was done through phone surveys based on these 3 standard modules. So basically we sat in one place and called the facility charges, and we found that this kind of assessment is good to urgently get information and put it into an automated system and get it ready to for decision makers quickly. Of course, it's important to engage management in this process. One needs to to have a very good planning ahead of time. And given that these are phone surveys, then we found that it is very important to do calls before you start the assessment, schedule up when you're going to call this facility in charges, and this allows for efficient implementation of the assessment. And of course, it is important to create time and the opportunity to adapt the tools to the country setting. And of course, have the team that is doing the assessment seated in a central location. In Kenya, it took us 1 week, 7 days to collect the data in these 132 facilities and 51 community units. Our next steps is just basically to further interrogate the data, compare it with our routine data, our baseline assessment, of course, disseminate the information with the policy makers, And we are also planning the next assessment. So this is something we want to be doing on a quarterly basis. So the next assessment, we have scheduled to do it in March, and we will take some of the lessons that we learned in consideration. So thank you so much, and sorry for taking a little more time. Thank you.
No problem. Thank you so much, Dr. Carey. I think that was so interesting. And I think, again, you addressed that dual track of both having to allocate resources for both COVID case management, but also assuring the continuity of essential health services. And in this presentation, highlighting the need for real-time data to identify the bottlenecks, the major gaps, in order to be able to supply or guide the supply or guide the deployment of supplies and vaccines as they come on board. Really very interesting. Thank you very much. So with that, I would like to invite Dr. Mahmoud, who is the founder and president of the Hope Foundation for Women and Children. Dr. Mahmoud, you have 10 minutes, please, and the floor is yours.
Hello, I'm Dr. Iftikhar Mahmood. Thanks for inviting me, and I'm right now. I'm going to be presenting our experience at Hope Foundation in Cox's Bazar, Bangladesh. Hope Foundation is a small organization, but we have quite a bit of experience through the pandemic. I'll be sharing our struggle, our success and experience with the audience. Thank you so much. And next slide, please. So I'll be talking about our COVID units and how we provided PPEs to all the staff across our 26 facilities, and how we provided trainings for clinical, non-clinical staff, collaboration with the government agencies, WHO, and all international and national organizations in that area. I want to also just emphasize that Cox's Bazar became well known in 3 years ago when it hosted almost 1 million refugees from Myanmar, and we work in that area. So it is a very significant area because of that, the fragile community. We also partnered with the local community, the refugees and the host community people, and we used local resources during this pandemic. Next slide, please. So Hope Foundation has been serving in Cox's Bazar, southeastern part of Bangladesh, is a district, since over 21 years. We have 2 hospitals. One is in the host community and one inside the refugee camp, a field hospital. We run 8 sexual reproductive health centers inside the camp. And also we set up 15 birth centers across the district. We are a maternity care organization, and also we train midwives. Next slide, please. So this is our Hope Hospital. It's a 40-bed maternity hospital. We established this in 2005. It's about 16 years ago. We serve the local community through this hospital. Next slide, please. COVID was first diagnosed in Bangladesh sometime around March, but we have been aware of this since the pandemic broke out in China, and we have been worried when WHO declared that this is going to be a pandemic. We thought, what we can do as a small organization in the remote area. At that time, we are under construction, a maternity and fistula center. You see the 6-story building. So we quickly decided to repurpose this building, under construction building, to set up a 50-bed COVID hospital to serve the local community. Next slide, please. So this is a view of the Rohingya refugee camp. There are over 1 million people and in 26 square kilometers. And it's very densely populated. It's over 40,000 people per square kilometer in this camp. Next slide, please. In 2017, around August, the refugees started coming. So we quickly set up a field hospital, 50-bed Hope Field Hospital for Women. In the end of 2017, we've been running this hospital with support from our partners. We established this hospital through generous support from Islamic Development Bank. We are the organization that provide 24/7 emergency obstetric care, neonatal care, pediatric care, and whole range of services. Next slide, please. So in March, again, when the COVID started spreading in Bangladesh, we quickly set up tents inside the camp because all the modeling was showing that there will be thousands of deaths and hundreds of thousands of people will get infected. So we did our little part and set up some tents immediately. But also, we started reaching out to our funding agencies for support, how we can do something more steady, more better structure. So next slide, please. We started constructing this COVID hospital next to our field hospital with support from our donors, again, the Islamic Development Bank, World Bank, Direct Relief, UNFPA, King Abdullah Foundation. They all were very generous to come forward to help us and doing this. Next slide, please. So we built this COVID hospital in 6 weeks. And because there was a lockdown everywhere at that time, we started building it in March and we finished it in early May. And this hospital has inside there are 26 units and each unit is separated. And we build this with the guidance from experts around the world who are experienced setting up field infectious disease hospitals in very low resource setting. Next slide, please. So I will, as I said, I will be sharing our struggle and experience and success. So we'll be talking about our organization, how we survived in this. Now, first of all, I think the most important element was leadership. So we have good team on the ground and very strongly motivated, committed leaders who are ready to take risk. And because when the pandemic started, everyone were very, very scared, because what we hear from all over the world that people are dying, people are getting very sick, especially the frontline worker. So luckily we have very motivated leadership who actually took the charge. And we got the funding agencies along our side. We built infrastructure very quickly. We provided guidelines for our clinical, non-clinical staff. We set up labs. We waste management system. We were able to separate COVID unit and non-COVID unit for patients. Next slide, please. And we were able to recruit additional staff quickly and retain them. It was a great challenge to have committed staff in the front line. We were able to get new equipment, supplies. We focused on our safety, safety and well-being of our staff. We were able to get excellent PPE from our partners, especially the Direct Relief. I must thank they were very quick to send us from the US high quality PPE, which boosted the confidence of our staff a great deal. And we provided training in infection prevention, clinical management. Also, we involved our communities, host community, as well as the Rohingya community. Next slide, please. So a COVID response number I want to share with you in our experience is we have consulted over 14,000 COVID patients, COVID suspect patients. We admitted close to 900, mostly for observation and isolation and some for treatment. because the community, Rohingya community, lives in a small shack, and in each small tent, they probably 6 to 10 people live there. So there was no way to separate them, isolate them in their homes. So whenever anybody was suspected, we made sure we keep them. I think that all the other agencies inside the camp did the same practice. So these people who are suspected of COVID, they don't go back and spread the infection in the community. We collected over 1,800 samples. We only got 31 positive PCR, no fatalities. And in our center, we also did conducted birth from the COVID suspect patients. And just to let you know, in the Rohingya camp, only a few hundred patients got positive. And there was only 10 fatalities since March. So the cases were very small and the fatality is very small. I think it's a very interesting case. I would ask the world community to look at this, how it was managed so well, the so low fatality and low rate of infection. I commend to our government, our RRC administration, and also WHO and other UN agencies who were really strongly managed this camp very well and restricted movement and provided support, contact tracing and all this. And it was a huge success. I would ask the world community to look at this, how it was done so well. Thank you. Next. So this is about HOPE services. We usually provide a consultation and services to about 200,000 patients annually. But in 2020, our services went up tremendously. We served more people, almost 300,000 people we served last year. And among them, I just put some numbers here that we have observed that mental health consultation was up tremendously. Also, emergency C-section and also some birth numbers went up as well. Next slide, please. So this is, I'm gonna show you some images of our field COVID hospital. This is the waiting room. As you can see, it is well spaced, many windows. We made sure that there is well ventilation. As we know, in low setting, we cannot do negative pressure, positive pressure, and air conditioning and all this. So we made sure that contamination, transmission is low in a gathering or like where the people together. Next slide, please. This is our consultation area where patients come, and again, it's well spaced. Next slide, please. The sample collection booth. Next slide. This is our women ward, the women's section there, one of the women's sections. Next slide, please. This is the men's section here. And again, as you see, there are many exhaust fans, big windows, and our staff are well equipped with PPEs. Next, please. So this is the patient receiving high flow nasal cannula oxygen supply. This is one step below mechanical ventilation. We don't have any mechanical ventilation in our hospital. Only district hospital recently got mechanical ventilation ICU, and only few hospitals actually got the high flow nasal cannula. This is expensive, as well as for our area at least. And also we are able to set up central oxygen supply for both of our hospitals. And this high flow nasal cannula was able to help many patients. Thank you. Next, please. This is our delivery suite. As you see, they are well, our staff is well protected by PPE, and we conducted the delivery from COVID suspect patient. Next. This is our operation room. This is open 24/7 inside in our both hospital, but most importantly inside the refugee camp. Our staff were dedicated and they have done a tremendous job. I want to thank them. Next, please. So this is again the COVID hospital inside the camp, and this is well designed. And we divided the green zone, yellow zone, red zone, different entrance, different exit, and we got support, guidance from different experts all over the world, just to show you how it is done. Next, please. So this is our emergency response team. We set up emergency response team since we started engaged in refugee care, because our area is prone to different natural calamities. Next slide, please. So our emergency response team, we have good motivated leadership, well-trained people, and we have a very well-equipped setup. We do periodic drills, and we partner with health sector, WHO, UN agencies, and government agencies. We stockpile supplies all the time. And this team actually, this experience helped us a lot to engage in the COVID response that we did last year. So I think that this is a good experience for us, having that response team. Next. So I want to emphasize this rapid hospital readiness checklist for COVID-19 developed by World Health Organization. There are 12 indicators. We assessed our work against these 12 indicators. As you can see, we scored 100% in all indicators. This is an amazing success, I would say that, and I would recommend all the hospitals that work in low resource setting that we must, and should look at this and how we are performing, because this gives us the confidence that we are maintaining quality and standard across the board. Next, please. This is just a graphic representation of that 12 checklist from WHO, just to see, like the visually see that we have achieved 100% in all indicators. Next, please. So challenges, of course, there are many challenges all over the world. I live in the US right now, and I see how the fragile, the health system of the most advanced country in the world, So in Cox's Bazar, a place like Cox's Bazar, and I have, like the honorable presenter from Kenya were, presenting. It is so astounding that what kind of work are being done in the third world countries. And we say, as I say, we have many challenges, but I'll just mention quickly the funding challenges there, building infrastructure, supply chain, logistics, equipment, all this, misinformation with the providers and the patient community. And during the lockdown, strict lockdown, the limited movement, and is an impediment to getting the supplies and medicines that to serve the patient. Also getting the approval from the authority is also challenged, because many times their offices are closed because the people couldn't come to work. Next. Next, please. And staff burnout and staff sickness. One of our gynecologists, he got infected with COVID, and he was in ICU for 3 weeks in another town, and tertiary care hospital, and he was in the hospital for about 2 months. And luckily, he survived. He came back to work in few weeks back. He came back to work with more strength and more resolve. And we had few staff got infected, but luckily, nobody had any bad consequences. And other challenges that COVID work. Some of the staff, they really needed more incentive to work and a financial incentive. And what we work in that. Because it's an international setup for the refugees, but many of the international organizations had to go back because of the restrictions and all this. And so our workload increased. Next slide, please. So opportunities, how we got benefited. Of course, first of all, we got a very good team building experience. We learned many skills, new experience. We were able to closely collaborate with the government agencies, again, WHO's, UN agencies, international organization, and collaborated with new funding agencies like World Bank and some other, funding partners. We are able to collect data, but most of all, we are very proud of serving the humanity. And this was a test for us. And I think that we have done reasonably well. and our team spirit is much higher than before. Next, please. And future guidance, one thing I have to say that, I think all of the organizations that work in the low resource setting, they should have a very good infectious disease outbreak preparedness plan, because even in a smaller scale, it will save lives. It will save lives of the patients as well as staff. So that definitely we're going to do focus on and more, and develop strong emergency response plan, and ongoing training and management, infection control, stockpiling supplies 3 to 6 months at least. Community partnership is very, very important. Engaging the community, getting the volunteers from the community, and giving some training all the time. And they will be very helpful during the crisis time. And also we need to invest in research and data collection. How we are doing it, what should be our, so we are trying to partner with research organization and to, publish our finding as well. Next, please. This is, like one of the last slides. I just wanted to highlight the contribution of the midwives. And we have a midwifery school, and we train and employ lots of midwives. And they were in the front line, along with the doctors and nurses and other clinical staff. But they are tremendously brave, and they have, as I said in the beginning, we are a maternity care organization, and I really salute the midwives that contributed so much to our work. Next slide, please. I want to thank our partners for technical support, the Ministry of Health, Government of Bangladesh, Refugee Relief and Repatriation Commission was tremendous help. WHO was always with us, and I'm thankful for inviting me to this event. And funding agencies, I couldn't do it. We couldn't do it without their support. Islamic Development Bank, World Bank, UNFPA Bangladesh, Direct Relief, King Abdullah Foundation, Accelerate Energy, Fistula Foundation, Every Mother Counts, and Kulzik Foundation. I would not do a good service if I don't mention their name. Thank you. That's where I will stop. I appreciate the time.
Thank you so much, Dr. Mahmood, for sharing this truly remarkable experience from Bangladesh, reminding us and highlighting the impact of COVID on the most vulnerable and the most marginalized populations, but also giving us hope in terms of the response that is possible through good leadership, through good coordination, both locally, nationally, and global, but also with attention and investment in staff training, support, safety, and well-being. So thank you very much for that. And I'm sure there will be some questions for you, but I'd like to move on quickly now to invite our last speaker of this session, Dr. Carol Fry, who is a technical officer in the Infection Prevention and Control unit at the World Health Organization and headquarters. Dr. Carol, you have 10 minutes, please.
Thank you. Firstly, thank you very much to the organisers for inviting me to contribute to this session. My brief is to talk about preparing sort of COVID vaccination clinics, looking particularly at the infection prevention control procedures. And just to say that out of scope is vaccine supply and vaccine efficacy. Next slide, please. So 2 key documents to bring to your attention if you're not already aware of them. There's the guidance on deploying a national deployment and vaccination plan. This was published in November. This is a comprehensive WHO publication. And then just a couple of weeks ago, WHO published an aid memoir on IPC principles for COVID-19 vaccination activities. And I think it's important to note that this document is bringing together information on IPC from a sort of disparate group of documents. So it's not actually new guidance, it's just reiterating agreed best practice. Next slide, please. So here we believe we've set out the sort of the principles for safe vaccination of against COVID-19. It's about the use of standard precautions, additional infection prevention control precautions where these are necessary, training of staff, which has been, I think, been mentioned by all the speakers as being critical to safe working. We also look at the environment, and I think that was shown very nicely in some of the Hope Hospital slides. And also it's looking at your own national guidance and protocols. Next slide, please. So in the aid memoir, we've divided up the information into two phases, which I'm sure will not be a surprise to anybody on this call. Firstly, looking at preparation and planning, sort of thinking ahead about staffing, back to training, looking at the environment, looking at local policies, and also, as other speakers have remembered, looking at the IPC supplies that are going to be needed. And then moving into the operational phase, looking at just reinforcing what people should know and should do anyway, be familiar with. So it's about hand hygiene, appropriate use of PPE, which is really important when it comes to these clinics, injection safety, and maintaining that safe environment. Next slide, please. So we list what we believe are important sort of local IPC guidances and standard operating procedures to make sure that you have these in place, ideally ahead of you, well, ahead of your vaccination program. So it could be screening policies to make sure, because the people arriving for vaccination do not present with symptoms of COVID, looking at your key IPC measures, cleaning and disinfection, which I will keep coming back to because we know that is critical in a safe environment. Obviously, these clinics will generate waste, so it's making sure you've got environmentally friendly waste treatment methodologies about this extra waste that is being generated. We find that visual reminders to both staff and people receiving the vaccination are important about physical distancing, keeping safe, hand hygiene, respiratory hand hygiene. That is, if you're sneezing into your tissue, throwing that away into a bin with the lid on it and cleaning your hands. And it's training materials for both the staff and for the public. Next slide, please. And as we've already mentioned, you will need to have adequate supplies. In terms of PPE, it's mostly medical masks for those vaccinating, but clearly we also want people presenting for vaccination to wear a face mask to minimize the risk of them potentially infecting others, because as we know, there are a significant number of people that are positive for SARS-CoV-2 that may not exhibit symptoms. And these are the equipments that you will need to run a safe vaccination clinic. Next slide, please. As I keep reiterating, the physical environment is really important. And I know we're talking about hospital clinics, but really these principles apply to any environment where you're going to offer COVID-19 vaccination. Ideally, we would like to see separate entry and exit points, and ideally we'd like to see a one-way flow of patients in these spaces, as is illustrated with some of these photographs. And it's about making sure your vaccination stations are well spaced and to make sure there are sufficient hand hygiene stations, and also you've got sufficient space for vaccine storage and preparation. Next slide, please. And these are just, again, some photographs of seeing this information being used in the field about sufficient spacing. Obviously, good ventilation, as our previous speaker mentioned several times, is really important, be it sort of natural or mechanical ventilation. And all of these things, if you can plan ahead as to how you're going to configure your vaccination clinic, will make it as safe as it can be for both the staff and those coming to presented for vaccination. Next slide, please. So this is really the nub of the infection control advice for vaccination sessions: hand hygiene. You can never have too much hand hygiene, and this can be with alcohol-based hand rubs or soap and water. The PPE for a vaccination clinic is a medical mask for those vaccinating. Then again, we're reiterating the importance of the environmental cleaning and disinfection, especially those high-touch surfaces, and we think those should be cleaned on a very regular basis. And also it's important to remember safe injection practices and safe disposal of waste. As I said to you, the aid memoir that we've published is reiterating existing WHO guidance, But to check that that guidance was still valid, we consulted our international group of IPC experts to make sure that we didn't need to modify or moderate that advice before we published the aid memoir. And obviously with everything that relates to COVID-19, the evidence base is kept under very regular review. And in fact, there is a concurrent webinar being held at the moment looking at the implications of the new variants and as to whether or not we need to modify our advice on that. So that is actually deliberating at the same time as this meeting. Next slide, please. So in terms of PPE, as I've said, really it is just medical masks of vaccination clinics. Gloves are not indicated, and I will come to that in another slide. At vaccination clinics, you will need to have a small supply of the other PPE, such as gloves, gowns, and eye protection should somebody develop symptoms while they're there at the clinic, but they are not required for routine COVID vaccination clinics. Next slide, please. Hand hygiene, what we recommend is the use of alcohol-based hand rub between each vaccinee, each person receiving their vaccination. This is consistent with the WHO 5 moments. And actually, if you look at the aid memoir, there's an explanation as to how that does fit in with the 5 moments. So we are consistent with our own advice. Next slide, please. And of course, hand washing with soap and water is always important to make available for visitors and staff. Next slide, please. So this is the guidance on gloves not being indicated for IM or intradermic injections. And in fact, this goes back to 2009, which is why it was very important we talked to our group of international experts. They are absolutely unanimous that gloves are not required for vaccination in COVID-19 vaccination clinics. And they're equally very strong in their advice that we do not want people using alcohol-based hand rubs for disinfecting gloves. That can damage the integrity of the glove and should strongly be discouraged. Next slide, please. And this is to remind people about safe injection practice, because obviously we don't want people, the law of unintended consequences, people having sharp injuries as a result of giving COVID-19 vaccination. Next slide, please. And this is a reminder that it's important that as well as using sharps safely, it's also important to dispose of them safely. And these safety boxes should be sealed when they are 3/4 full and stored in a safe place until they can be properly disposed of. Next slide, please. And this is to remind you about the environmental cleaning. I think it's probably a local decision as to how often different areas are cleaned. We do strongly encourage people to minimize clutter because that makes cleaning much easier. And also the cleaning is important because, as I've said already, you will have people presenting at these clinics that could be SARS-CoV positive and don't exhibit symptoms. And so we want to minimize that risk of transmission to others. Next slide, please. These are some resources that build on what I've already included in this presentation. And then next slide, please. My final slide is to remind you about these health service capacity assessments, which have been used by some of the speakers to help you assess your readiness for different aspects of COVID-19 care and vaccination clinics. And thank you for your time.
Thank you, Carol, for another excellent presentation, this time focusing on the importance of the work on the guidance and tools that are available to support countries in their efforts. And IPC, of course, is central to the response and case management of COVID-19 and will also be critical for safe introduction of vaccine activities. So I would encourage all the attendees to look up the links to that Carol has provided, and we can send in the follow-up on these different assessment tools and guidance that are available for those countries who want to strengthen that component of their response. So with that, I have, currently I have maybe just time to maybe select one question that I can ask to, which has now disappeared from my box. So I'm going to ask the question to both Kudsia, very just quickly, to both Bangladesh and Kenya on so as a question came in, is there any strategy development for example, district health officers to deliver PPE to key populations, such as people with disabilities, refugees, asylum seekers, etc.? Just if we could have a very quick response from both any of our panelists, and then what we will do is we will provide written responses to the other questions that have been posted in the Q&A section, and we will send those to you. So Dr. Mahmood, may I invite you to respond to that question?
So the PPE, the question about supplying PPE for the special group of people who are disabled, and what is the other?
That was just, if we could just quickly respond to that question. Is there any strategy to deliver PPE to those key populations? And if there is, are you able to share any best practices around that?
So what I know that, in our area, there are many non-government organizations there, the social organizations that's distributing mass scale mask for the community most like disadvantaged communities. So that is all I can say, but I'm not aware of the government strategies, but government right now currently working on the vaccination strategy that I know. Bangladesh just started the first vaccination yesterday, and we have received 2 million vaccine yesterday, and we are working on vaccinating our frontline and most vulnerable population.
Great, thank you. In the interest of time, I think we'll stop there, and then we will submit the responses to all of the other questions in writing and share that with the whole group of participants. So once again, I'd like to thank again all of the excellent all of the panelists for their excellent presentations. They were very different, based in very different contexts and capacities, but there were a lot of kind of common messages and themes across the board, I felt, and in terms of the importance of leadership, the staff, safety and well-being, retention, the community partnership and engagement, the role and importance of using some of these standard guidance and assessment tools, and of course the need for cooperation and a coordination, and the need for all countries and facilities to have these preparedness, emergency and response plans for future crises. So with that, I would like to invite Ms. Anna Thorland to give us some closing remarks. Over to you, Anna.
Thank you, Ms. Catherine O'Neill, for your excellent moderation of this webinar. The COVID-19 pandemic has shown that existing strategies for pandemic risk management in many countries were not adequate in dealing with the impact of the current public health emergency. A systemic approach to disaster risk reduction and emergency preparedness is needed by engaging all relevant sectors, in particularly breaking down existing silos between disaster management and health workers. In 2016, UNDRR hosted the International Conference on the Implementation of the Health Aspects of the Sendai Framework for Disaster Risk Reduction, where it was a consensus around what has become known as the Bangkok Principles. At that time, the Ebola epidemic in West Africa and the Zika virus outbreak has both demonstrated the need for a multi-hazard approach to strengthen health system resilience and to integrate health emergencies into disaster management systems. More than 4 years later, the COVID-19 pandemic has further confirmed how urgently this integration is needed. Yet, in response to COVID-19, many countries set up pandemic governance structures that include health ministries, disaster management agencies, and a variety of ministries such as security, social services, information, and education, to name a few. This is because governments recognize to mount a full spectrum response, it was important to strengthen coordination between relevant ministries, stakeholders, and communities. Moving forward, This type of cross-sectoral collaboration needs to be maintained and extended. It is just as important that health emergency strategies and preparedness plans be aligned with disaster risk management plans to ensure strengths of each are utilized and gap addressed. UNDRR have available for local authorities the Public Health Scorecard Addendum, and we are finalizing our works into action on integrating health emergencies into disaster risk strategies and plans. As we come to the end to our first webinar in this series, UNDRR would like to thank our co-organizers, the World Health Organization and the International Federation of Hospitals, and the speakers for your expertise and for sharing with us tools, guidance, country practical experience in managing disaster risk in hospitals, field hospitals, and continuing health services during a pandemic. And we thank you, participants, for responding to our call. Thank you very much.
Thank you very much, Anna, for those inspiring closing remarks. And by way of concluding this, what I believe to have been an excellent and hugely interesting session, let me take this opportunity to one more time thank the excellent presentations, thank all of our panelists. A special thanks to the organizers who are hiding behind the scenes, Dr. Koudzia and Dr. Jazz, along with our colleagues in UNDRR, excuse me, and the Internet IHF. Thank you again for all of the participants. What a great turnout. Let me remind you all that the next webinar in this series is scheduled on the 25th of February, and the link for the rest of the webinar series is shared in the chat box. So please do have a look at that and share it with your network for early registration. As we said, we will send you some of the written responses and the other links to the other resources that have been mentioned, along with the presentations, the excellent presentations of our panelists. And we look forward to seeing you all then at the next webinar series. So in the meantime, please also reach out to us should you like to share any experience at this platform. And please, courage to all of you, and really please keep safe and bonne continuation. Thank you very much. Bye-bye.